Good day, dear students. Our topic for today is acute respiratory infections, acute bronchitis, and community-acquired pneumonia in outpatient settings. Except this disease, of course, in differential diagnosis with acute respiratory viral infection will pay a lot of attention to coronavirus infection. Now we'll start with upper respiratory tract infection. Upper respiratory tract infection, URI, are illness caused by an acute infection which involves the upper respiratory tract, including the nose, sinuses, pharynx, or larynx. These commonly include nasal obstruction, tonsillitis, pharyngitis, laryngitis, sinusitis, otitis media, and common cold. Acute respiratory disease, ARD, or viral respiratory infection, VRI, are viral infectious disease of the upper respiratory tract that primarily affect the nose. The throat, sinuses, and voice box may also be affected. Without a doubt, ARD is the most well-known upper respiratory tract infection. Other types of URI include sinusitis, pharyngitis, epiglottitis. Influenza and COVID-19, on the other hand, is not an upper respiratory infection, not URI, because they are systemic illness. So, URI are very common viral disease, mostly viral disease, which affect mostly nose, pharynx, larynx may be involved, and last not too long, mostly within 7 days, they self-terminate. They don't have severe clinical cause as a rule. Viral upper respiratory tract infection, characterized by rhinorrhea, nasal congestion, headache, and as a rule, subfebrile temperature. Maybe sneezing, but rare can be coughing. Causes of upper respiratory tract infection, mostly viruses, rhinovirus and adenovirus. More rare can be bacteria. So, to use antibiotics is not a rule for upper respiratory tract infection because they are not effective in this case. This disease, as a rule, has benign clinical cause, and antibiotics don't affect viruses. They can lead only to diarrhea and other gastrointestinal disturbances due to dysbacteremia. We shouldn't use these drugs for viral infection to prevent side effects and development of community antibiotic resistance. What is rhinovirus? One of the most common causes of common cold or URI. It's widespread, but more in the nose. It spreads through the droplet or through the contact, mostly during inspiration, during inhalation of ambient air. We inhale also droplets with virus. Incubation period is very short, 1 to 3 days. Compare please with coronavirus infection, it up to 7-14 days. Symptoms: indisposition, low-grade fever, runny nose, pharyngitis, conjunctivitis, submaxillary and lymphatic nodes enlargement. And diagnosis: polymerase chain reaction. This reaction is the best method to identify different viruses, including coronavirus infection. But in case of rhinoviruses, clinical cause is benign and not as a rule lead to severe complications, so no need to do so costly and not so simple method for the diagnosis of URI. Adenovirus, also widespread. Droplet and contact is pathway. Incubation period something longer, average 6 days. Maybe few clinical forms. Adenovirus is more spread in our organism compare with rhinovirus. Rhinovirus mostly rhinitis, adenovirus, except rhinitis may lead to pharyngitis, tonsillitis, acute bronchitis, conjunctivitis, keratitis, and even to pneumonia. But in this case, it is not URI, it is lower respiratory tract infection. And also polymerase chain reaction is the best way for diagnosis. But no need in our outpatient department, we don't use PCR for diagnosis of adenovirus or rhinovirus. Clinical features of acute respiratory disease or upper respiratory tract infection with viral etiology. Typical symptoms: rhinorrhea, nasal congestion, sneezing, coughing, sore throat. Accompanying symptoms: low-grade fever, usually lasts up to 3 days, headache, mild diarrhea, fatigue, loss of appetite. Before coronavirus pandemic, we usually don't pay attention to this type of infection and very commonly don't uh, stop our work. For example, students very commonly attend classes when they have these symptoms. But to stop spreading of this type of infection, better to isolate person. So in case of subfebrile temperature, in Russia, it is a rule to give sick leave to patient for 3 to 5 days for period of high temperature and period of uh, high level of virus in the patient organism, and in this case patient may be dangerous for other healthy people. To prevent spreading of this non-severe viral infection, better to isolate patient. And acute respiratory disease or common cold is non-severe situation. More severe situation is influenza. And now we mostly are speaking about coronavirus infection. But before coronavirus, we had more severe infection, which called influenza. And how to differentiate upper ARD with influenza. In ARD, fever is rare, usually subfebrile temperature. In influenza, temperature is febrile. Headache, more severe, mild diarrhea maybe, malaise, influenza. I already told you that it is not focal disease. It affects different organs and system. It can lead to arthralgia, mild diarrhea, can lead to diarrhea. And extreme fatigue influenza can cause. Both these diseases, common cold and influenza, may lead to nasal congestion, sneezing more typical for upper respiratory infection compared with this inflammation. And chest discomfort more severe in influenza. Influenza more commonly affect lower respiratory tract compared with ARDs. Diagnosis of acute respiratory disease, ARD. Symptoms and physical examination are all the doctor needs to diagnose common cold or ARD. It's another name of RD is common cold in community. So in this case, mostly diagnosis is done by symptoms. And blood test or X-ray are not done except situation of epidemic. Now, of course, it is done always because we are afraid of coronavirus infection, and we have to differentiate any sneezing, any coughing to exclude coronavirus infection. During physical examination, the doctor will pay careful attention to the head, neck, and chest. So examine the eyes, ears, throat, and chest to help determine if a bacterial source is causing the illness. We have to exclude during examination lower respiratory tract infection, so we have to check breathing, to check rails, mostly wheezing, maybe to exclude moist rails in case of pneumonia. ARD are self-limited, usually lasting up to 10 days, average duration 1 week. Therefore, management is directed at symptoms relief rather than treating the infection. Antiviral drugs rarely used for uh, adenoviral or rhinoviral infection. Multiple remedies, including complementary and alternative medicine products, over-the-counter products, and prescription drugs have been used to prevent and treat ARD symptoms. So we commonly use, all of us suffer from this type of disease, and we commonly use OTC products to treat it. Except it, we may use other symptomatical treatment. Now I may give you a few examples of OTC products. For example, hypertonic nasal spray, physiomel, aflubin maybe, and other different drugs also can be used. There are a lot of drugs. Maybe most spread group of drugs are anti-common cold drugs. Therapies not effective for common cold or ARD. Antibiotics, I already told you, it is viral infection. Antibiotics shouldn't be effective, will lead to antibiotic resistant and dysbacteremia. Caffeine, no need. It's not so severe cough to suppress it with codeine. Codeine. Intranasal corticosteroids, no need. It suppresses immunity and will lead to growth of viruses. So no need to use corticosteroids intranasal. And vitamin C is effective for prophylaxis, but not effective for treatment of this infection. Mostly we use to treat common cold or ARD decongestants, which include epinephrine, pseudoepinephrine, phenylepinephrine, nafalazine, oxymetazoline, tramazoline, xylometazoline. So we use drugs which constrict vessels. It's prevent nasal congestion because if vessels lumen is narrow, less blood will go outside of these vessels to the nasal cavity and congestion decrease. But if we use higher dose of these drugs, it may lead to systemic effect, stimulation of sympathetic nervous system, and can cause elevation of blood pressure, tachycardia, headache. So I don't recommend you to use decongestants so commonly. Better to use it when you go to other people's. For example, if you plan to attend classes. For prophylaxis of spreading of infection, to decrease viral spreading, to decrease sneezing, you may use decongestants. You will be less dangerous for surrounding healthy persons. But at home, Better not use this group of drug when you are alone, I mean. Better to help our organism to eliminate viruses, because when vessels are broad, this viruses is eliminated from the vessels and from the organism also. There are a lot of macrophage, lymphocyte, different other types of leukocyte which kill these viruses. So for visiting some meetings, better to use. When you are alone, better not to use big distance. The same recommendation for antihistamines. They decrease or congestion of the nose. Anticholinergic the same. Non-steroid anti-inflammatory drugs, and I put it here paracetamol, but it's mostly antipyretic, not anti-inflammatory drug. It has anti-inflammatory property, but mostly it is antipyretic. If patient has higher temperature, you may use naproxen or paracetamol. If temperature is subfebrile, better don't decrease. If it is less than 38 degrees of Celsius, it's not affect patient's condition so much. It not disturb patient so much. But this elevation of temperature helps our organism to eliminate infection. In this situation, our leukocyte became more active and viruses became less active. Commonly recommended fluid intake and forced diuresis, and very commonly we use humidified air. There are a lot of complementary and alternative medicine products for the common cold. I may list only few of them. As I know from Indian students, they very commonly use tulasi or tulsi, and Indians, as I know, used it not only for common cold. They used it for different disease and for prophylaxis. It is possible it may be helpful. In our country, more commonly we use echinacea or geranium. Also possible to use other drugs like zinc acetate or gluconate. No, and here are Pelagorium sidoides, which is commonly used in our country. We have this flower in our rooms for cleaning the air in our rooms. It is beautiful flower and also helps in prophylaxis of infection. And Andrographis paniculata also can be used to decrease inflammatory symptoms. Another example of OTC products are Lizabac, Cialor, which contain uh, silver, and all of them believed be effective. But really, we don't know because it is not proved. They are not harmful. Are them helpful? Not proved by big clinical trials. Prophylaxis of ARDS may include vitamin C, garlic, and of course, frequent hand washing, face mask. About garlic and vitamin C are questions, but it is obligatory to wash your hands and to wear face mask, especially in situation of coronavirus infection. And now we'll speak specially about coronavirus infection. I'll try to give you the newest recommendation from Russia, the newest guidelines, and also some recommendation from United States newest guidelines. What is coronavirus? Coronavirus are positive strange RNA viruses with a crown-like appearance under an electron microscope. Corona is the Latin term for grown, due to the presence of spike glycoproteins on the envelope. Well, they are very famous spike glycoproteins on the envelopes, and many drugs and vaccines they used in many drugs and vaccines for coronavirus infection. Another name, more scientific name of coronavirus is SARS-CoV-2. It has round or elliptic and often form, may has pleomorphic form, and a diameter of approximately 60-140 nanometer. Like other coronaviruses, it is sensitive to ultraviolet rays and heat. So in open air, when there are sunlight, its leaf maybe few hours. But when there are no sun, no ultraviolet rays, it may live on the surface for a long period of time. It may last up to 3-5 days. It is RNA viruses, so it is important for the diagnosis of this disease. And now I will tell you some definitions from Russian guidelines. We divided COVID-19 cases to three groups: suspected cases, probable cases, and confirmed COVID-19 cases. Suspected COVID-19. Now we suspect COVID-19 in all patients with flu-like symptoms and temperature more than 37.5 degrees of Celsius. Suspected COVID-19 is a person with acute respiratory illness with no other etiology that fully explains the clinical presentation. This patient obligatory have to have fever more than 37.5 degrees of Celsius and at least one symptom of the respiratory disease, maybe few symptoms. And symptoms of respiratory disease include cough, shortness of breath, chest discomfort, low oxygenation, saturation is less than 95%, loss of smell, maybe taste, conjunctivitis, diarrhea, myalgia, headache, rash. Even from these symptoms, you see that COVID-19, of course, may affect only upper respiratory tract. But as a rule, it is systemic infection, which affect gastrointestinal tract, cardiovascular system, lower respiratory tract, and may affect muscles and joints also. And I want to pay your attention on some diagnostic uh, procedure. It is saturation. Normal saturation is more than 98%. But diagnostic value for COVID-19 is saturation less than 95%. So in all these signs and symptoms, there are only few values which measured in numbers: temperature level and level of saturation. And you have to remember these values. Probable COVID-19. It is the same, but also have to be some history. Having if patient uh, with these symptoms which we discussed above have been in contact with a confirmed COVID-19 case in the last 7 days prior to onset of symptoms. In previous guidelines, now current guideline version is guidelines version 15 in Russia. In previous guidelines, before Omicron before Omicron became widespread, this term was 14 days. But Omicron has low incubation period compared with other subtypes of COVID-19. So incubation period decreased up to 7 days. Another important features, if patient with symptoms of or with respiratory tract infection returned from other countries in the last again 7 days. And also important are imaging studies. If present typical changes in the lung in CT scan, independently of testing for COVID-19 and RNA result. You know that the most sensitive method is COVID-19 RNA results, but CT scan is also sensitive. And if clinical symptom is typical, if clinical symptoms are typical and CT scan shows typical change for COVID-19, we may give diagnosis of probable COVID-19 even if RNA is not found. Because this analysis, PCR, is very sensitive, but sometimes may give false negative and false positive result. Mostly it depends on the term after the onset of the disease. Sometimes viruses already goes down to the trachea, bronchi or lungs and is not in the nasal cavity for swabs and it's impossible to find these viruses, or some other mistakes in this procedure of containing this virus from the patient's organism. In this case, it is probable COVID-19. And confirm COVID-19 only if present positive result of PCR or immunochromatographic test. Immunochromatographic test is less sensitive than polymerase chain reaction. So preferable is polymerase chain reaction. But even immunochromatographic tests positive with typical clinical picture and even without clinical picture, if patient is asymptomatic, gives the diagnosis of confirmed COVID-19 infection. It is fast assay when doctor may take some material from the patient, put it on some small piece of paper which can be turned after the contact with viruses, which will turn its color after the contact with viruses. This assay is done very fast, maybe in 30 minutes or 1-2 hours. It is less sensitive than more long-lasting polymerase chain reaction, but it's included in the definition of confirmed COVID-19 infection in Russia. Now, who is a contact? It is important. Do you have contact with patient with COVID-19 or you don't have contact with COVID-19? Because if you have contact with COVID-19 infection, with person with COVID-19 infection, it means that you have high risk of accepting of this infection. So who is a contact? A contact is a person who is involved in any of the following: providing direct care without proper personal protective equipment for COVID-19 patient, staying in the same close environment of a COVID-19 patient, including workplace, classroom, household, catering, traveling together or in close proximity, less than 1 meter, with a symptomatic person who later tested positive for COVID-19. All these persons are contact. And who is high-risk contacts? Who has high risk to accept COVID-19 and became ill? High-risk contact are persons who touched body fluid of the patient, respiratory tract secretion, blood, vomit, saliva, urine, feces without special protective equipment. It means had direct physical contact with the body of the patient, shook hands, hugged, or took care of, again, without special protective equipment. Touched or cleaned the linen, clothes, or dishes of the patient. Lived in the same household as the patient. Anyone in close proximity, less than 1 meter of the confirmed case without precautions. No, especially when you have flight in the same fly, and in this case you have high risk of contact and of infect of the disease, especially if this flight lasts more than 2 hours. Passengers traveling in close proximity, less than 1 meter, for more than 6 hours, it's the highest risk, with a symptomatic person who later tested positive for COVID-19. Low risk patient, low risk context, sorry. I want to tell you that if you have contact with classmate with COVID-19, has low risk contact, low risk contact. It is written in our guidelines. So if some person in the group has COVID, for example, asymptomatic, don't know and come to the classes, other students have low risk of development of infection. No, of course, if there are big enough room and you are not sitting very closely to each other. So low risk contacts shared the same space, same class for school, worked in the same room, and not having a high risk exposure to confirm or suspect case of COVID-19. Traveled in the same environment, bus, train, flight, any mode of transport, but not having a high risk exposure. So travel in the same environment, in the same bus, for example, for 30 minutes. So long-lasting flight, high risk of infection of COVID if there is some person who has COVID infection. Traveling in the bus from one bus station to another bus station, not so long duration, so risk is low. Symptoms of COVID-19. 70% of patients experienced fever, cough, or shortness of breath. 36 had muscle ache, and 34 reported headache. So higher grade fever may be or febrile fever, not subfebrile. Cough and dyspnea are also common in moderate to severe clinical case. Other reported symptoms have included but are not limited to diarrhea, dizziness, rhinorrhea, anosmia, dyspnea, sore throat, abdominal pain, anorexia, and vomiting. So other symptoms very commonly involved in case of COVID-19 infection, the same like in influenza. Most difficult to differentiate these two diseases, viral infection. And it's COVID affect gastrointestinal tract, as I told you already. It may affect skin and lead to some rash, may affect heart, muscles, and joint. Thromboembolic events also occur in patients with COVID-19, with the highest risk occurring in critically ill patients. So don't forget about hypercoagulation. In case of moderate to severe and very severe infection, it may play crucial role in the clinical course of the disease. While the majority of cases result in mild symptoms, some progress to viral pneumonia, multi-organ failure, or cytokine storm. Uh, our topic today is outpatient disease. We'll speak mostly about mild clinical symptoms of COVID-19 infection, mild or moderate. Don't will not discuss severe or very severe because they have to be hospitalized always. And differential diagnosis. Now, for me, I already told that more difficult to differentiate COVID-19 with influenza or flu. COVID-19 has more long-lasting incubation period, and COVID-19 more commonly leads to some rashes, may lead to anosmia, may lead to loss of appetite and to diarrhea, more commonly compared with flu. And it started more gradually compared with flu. Flu has fast onset and temperature rise within first or second day. COVID-19 may start with mild temperature without dyspnea, but in patient who has low immunity, especially in patient who has low immunity, it gradually increase and may lead even to life-threatening symptoms and situations. And For COVID-19, now we have vaccine. This differential diagnosis I took from previous year. They write that they have that we have no vaccine. Now, fortunately, we have very high progress and we have vaccines, many vaccines which are available for all people. In Russia, I already use this classification. We classify clinical cases to four groups: mild, moderate, severe, and very severe. It is very important for prognosis and very important for general practitioner to know, do we have to hospitalize patient or we shouldn't hospitalize patient with COVID-19. Mild cases usually are not hospitalized. Mild cases we classify when temperature is below 38 degrees of Celsius. Patients has cough, fatigue, sore throat, uh, rare sneezing, sometimes some rash maybe, but all of these symptoms are not severe, no severe dyspnea and no severe hypoxia. In case of moderate COVID-19, temperature is more than 38 degrees Celsius. Respiratory rate from 22 per minute to 30 per minute. So dyspnea, but not very severe. It's exertional dyspnea as a rule. At rest, patients don't feel dyspnea. CT scan of the lungs presents signs typical for viral infection. Oxygen saturation is less than 95% and C-reactive protein more than 10 milligram per liter. In case of severe COVID-19, respiratory rate more than 30 per minute. Saturation less than 93%. So moderate from 93 to 95%. Severe less than 93. Partial pressure of oxygen less than 30 millimeter mercury. Clouding of consciousness. Patient may be unconscious, may be excited very significantly, may have not good orientation in the time and place. And he very commonly has low blood pressure, drop of systolic BP less than 90 millimeter of mercury and diastolic less than 60. CT scan of the lung presents signs typical for viral infection. And in very severe situation, patient characterized by permanent febrile temperature, independently of usage of antibiotic, acute respiratory distress syndrome, acute respiratory failure, They need artificial ventilation. They develop very low blood pressure due to septic shock and shows polyorganic insufficiency. And they have to be treated in intensive care unit. Severe cases should be always hospitalized, but not in intensive care unit. Moderate cases, there are some different situation. Now, when present Omicron, which rare leads to severe clinical cause, all moderate cases are hospitalized. We have enough places in the hospital and better, of course, to hospitalize patients with moderate clinical cause. But when Delta strain was common and there was high level of infection and high level of hospitalization, some persons, especially young persons without comorbidities, who is not living alone, who may take care from surrounding people, may be not hospitalized. They try to be isolated in their flat or in their house, but they have contact with doctor mostly by phone, and some relative may take care of him without close contact. Oi. Sorry, students, I have now some problems with internet. So wait, please, for 5 minutes. You have break for 5 minutes. I will normalize my internet. Я так зажала нечаянно мышкой, но у меня увеличка перестала переключать. Сделай мне, пожалуйста, обратно. Спасибо. Мгм. Так. You still have 4 minutes for break and then we'll continue. So let's continue. How to make diagnosis? To diagnose acute infection of SARS-CoV-2, the COVID-19 treatment guidelines panel recommends using a nucleic acid amplification test, it's another name of PCR test, with a sample collected from the upper respiratory tract, nasopharyngeal, nasal, or oropharyngeal specimen. COVID-19 treatment guidelines panel, it is the name of clinical recommendation in COVID management in United States. So the same recommendation is in Russian guidelines. Main diagnostic method is PCR reaction to find RNA of COVID-19. The panel recommends against the use of serologic antibody testing as the sole basis for the diagnosis of acute SARS-CoV-2 infection. The same for Russian guidelines. Possible to use antibody immunoglobulin M and D to confirm diagnosis, to see to observe patient the clinical course of the disease. Does he make high level of antibodies to COVID-19? But this method is less sensitive than RNA observation and is not indicated like first-line diagnostic method. The panel recommends against the use of serologic antibody testing to determine whether a person is immune to SARS-CoV-2 infection, because even low level of antibody may mean high level of immunity, because maybe not only humoral antibody immunity, may be high level of cell immunity, may be high level of lymphocyte which are active against COVID-19 infection. A priority system for diagnostic testing for COVID-19. Everyone who has symptoms that are consistent with COVID-19, as well as people with known high-risk exposure to SARS-CoV-2, should be tested for COVID-19 infection. Ideally, diagnostic testing should also be performed for people who are likely to be at a repeated risk of exposure to COVID-19 infection, such as healthcare workers and first responders. Testing also should be considered for individuals who spend time in a heavily populated environment, teachers, students, food industry workers, and for travelers. But it's only recommendation. A really strong recommendation is to test COVID-19, to do PCR in persons with clinical symptoms that are consistent with COVID-19. The abnormalities seen in chest X-ray of patients with COVID-19 vary, but bilateral multifocal opacities are the most common. The abnormalities seen in computed tomography of the chest also vary, but the most common are bilateral peripheral ground glass opacities, with areas of consolidation developing later in the clinical course of COVID-19. Imaging may be normal early in infection and can be abnormal in the absence of symptoms. So both methods are available and good method for the diagnosis of COVID-19. I mean chest X-ray and CT scan. But CT scan is more sensitive and changes in CT may be visible earlier than in X-ray. In case of COVID-19, X-ray is changed after 3, 5, 7 days after the onset of clinical symptoms. CT is changed after 2-3 days after the onset of the disease, of the clinical symptom. So CT, if available, if preferable, and characterized changes by ground glass opacities with areas of consolidation, mostly bilateral. They localized in both lungs and mostly in subcortical layer. The same for changes in X-ray. There are not ground glass opacities, but multiple opacities in both lungs in subcortical layer. But if patient even asymptomatic, some asymptomatic patient may have changed in these visualization methods. So obligatory, if you suspect COVID-19, you have, and you are a general practitioner in outpatient settings, you have to send this patient to PCR, to CT scan, and also measure temperature to him, of course, to do clinical examination, measure temperature, and check oxygen saturation. Uh, Maybe that's all obligatory methods in outpatient settings. But if patient has moderate, severe, and very severe clinical cause, he is hospitalized, and in the hospital there are many different analyses which should be done, and some of them has prognostic values. And what has prognostic values? High body temperature is associated with more severe disease and higher fatality. Lymphopenia also is bad prognostic value, has bad prognostic value, and especially lymphocyte count less than 2,000 is associated with poor outcomes. Neutrophil lymphocyte ratio greater than 2 was associated with high mortality. Lactate dehydrogenase, high level, high mortality. Cardiac troponin elevated, more high mortality. More long trombin time, more high mortality. Serum ferritin elevated, more high mortality. A high level of DDMER and very high level of C-reactive protein are associated with high mortality. Oh, I forget about one more obligatory analysis for outpatient except CT or X-ray and PCR. Uh, uh, One more obligatory method is CBC to differentiate is it bacterial or viral infection, to see leukocyte count and lymphocyte count. Management. Mild cases are treated at home. Moderate to severe cases, hospitalization to isolation ward. Moderate may be treated at home if there are lot of persons in the hospital and there are no places. Very severe cases, hospitalization to an intensive care unit, require artificial ventilation. And now we'll speak about management of non-hospitalized adult with COVID-19. You have to do supportive care. Considering the use of COVID-19 specific therapy for patients who have high risk for disease progression, who have high temperature, as I told you before, who has lymphopenia, leukopenia, who has immunodeficiency, who has high many comorbidities, especially cardiovascular or lung disease. In this case, you have to think about specific therapy. Also, you have to take steps to reduce the risk of SARS-CoV-2 transmission, including isolation the patient. When possible, patients with symptoms of COVID-19 should be treated via telehealth visit to determine whether they require COVID-19 specific therapy and in-person care. Not always, in case of epidemic, general practitioner may visit patient with COVID-19. First of all, he himself has very high risk of infection if he visits many patients. Also, he has no time, and in mild cases, may be enough to call by phone and to have recommendation. In moderate to severe, of course, patients should be seen by the doctor and he have to be hospitalized. Patients with dyspnea should be referred for an in-person evaluation by a healthcare provider. If dyspnea present, doctor have to see the patient and should be followed closely during the initial days after the onset of dyspnea to assess for worsening respiratory status. So if dyspnea present, it is as a rule moderate cases, not less than moderate cases. Management plans should be based on patient vital signs, physical exam findings, risk factors for progression to severe illness, and the availability of healthcare resources. And now, therapeutic management of non-hospitalized diet with COVID-19. There are common features and some differences in Russia and United States. What do we recommend in Russia? Antiviral therapy, antipyretic, and anticoagulant and inhaled corticosteroids, especially in moderate cases when they are treated at home. But even in mild cases, inhaled corticosteroids may be recommended. Antiviral include in our country favipiravir, molnupiravir, umifenavir, and also may be used not antiviral but no, drug which increase immunity, interferon alpha in nasal forms. Antipyretic may be given in case of high temperature, but if patient has mild case, paracetamol shouldn't be used. Inhaled corticosteroids, focal corticosteroids, if patient has dyspnea, possible to use it. And also sorry, oral anticoagulants may be given even in outpatient, not only in inpatient anticoagulants are given. Corticosteroids and anticoagulants, according to my opinion, has very high potential to decrease hyperimmune reaction to COVID-19. So if viral infection only started in the first days, patient should use antiviral drugs in the first week after the onset of symptoms. When temperature usually is not so high, dyspnea not so high, patient may use only antiviral drugs, and that's all. And also symptomatic therapy, for example, fluid intake, OTC medication, and so on. But if disease lasts longer and progress, it means that main problem is immune conflict. Uh, you have to recommend drugs which decrease hyperimmunity. First of all, inhaled corticosteroid. And this patient has high risk of hypercoagulation. So anticoagulants may be effective. In United States, what do they recommend for non-hospitalized adults with COVID-19? So, this treatment include also antiviral drugs, which are ritonavir boosted nirmatrelvir. In our country, Paxlovid is not used and not proved in our country, but United States prefer these antiviral drugs. Next one will be remdesivir and sotrovimab, but they recommend these antiviral drugs to persons who has high risk of disease progression. Especially it is important for sotrovimab and remdesivir because both of them are IV drugs. In Russian recommendation, all drugs are oral. Possible to use for outpatient. In the United States, there are some IV drugs, and it may be used only in inpatient. Also, if these three main drugs, first of which is Paxlovid, uh, are not available or have some contraindication, possible to use alternative therapies, antiviral therapies also, which include bebtelovimab and molnupiravir. So you see, in Russia and United States, mostly different antiviral drugs are recommended. And in United States, like antiviral, they use sotrovimab and bebtelovimab, which are also not approved in Russia yet, which are monoclonal antibodies against spike protein of COVID-19. These drugs are not available and not used in Russia. But for my own opinion, antiviral drugs very rare give higher effect. Because at the onset, maybe because at the onset of the disease, when temperature is not too high, patients think maybe it is simple common cold. Maybe it is not COVID. I will not treat. I will not use any antiviral drugs. And when patients start to use antiviral drugs, it is late and they became not effective. And what else in the United States they write about? There is insufficient evidence for the panel to recommend either for or against the use of inhaled corticosteroids for the treatment of COVID-19. In Russia, we recommend inhaled corticosteroids. In United States, they recommend corticosteroids IV in severe and very severe cases. In Russia, also the same IV in severe and very severe cases. Next recommendation of United States. The panel recommends against the use of anticoagulants and antiplatelet therapy for the prevention of venous thromboembolism or arterial thrombosis unless the patient has other indications for the therapy or is participating in clinical trial. So anticoagulants are not so commonly used in the United States. For me personally, anticoagulants are very effective even in mild to moderate cases of COVID-19, and I recommend to use it. I agree, according to my clinical uh, experience, I agree more with Russian guidelines. But you see, even big country clinical recommendations still have some differences in treatment. In future, I hope will be agreement and will be common recommendation for COVID-19. But I don't know, will it be? I am not completely sure in it. Так, what about previous treatment? So if person before COVID-19, for example, suffer from asthma and use regularly inhaled corticosteroids, it should be continued because even in early stage, inhaled corticosteroids in healthy person decrease elimination of viruses, but in person with asthma, it decrease oxygenation due to bronchial spasm. Patient will have severe hypoxia. So positive effect of inhaled corticosteroids is more prominent compared with its negative effect. So patient with asthma have to continue inhale corticosteroids even if he gets COVID-19. If person taking SAIDs, many patients have joint problem and use the SAIDs. Patients have to continue this treatment. Uh, and panel recommends that there be no differences in the use of antipyretic strategies between patients with or without COVID-19. So antipyretic may be used if temperature is high. Both guidelines, Russian and United States, recommend its usage in case of high temperature like symptomatic treatment. If patient has, for example, hypertension and use AC inhibitors or angiotensin receptor blockers, he have to continue it. It not affect clinical cause of COVID-19. But uh, for treatment of COVID-19, both these groups are not effective. There are no clinical trials that prove its effectiveness. Statin also have to be continued. Many patients have ischemic heart disease and for lifelong course of statins. They have to continue, but they are not effective against COVID-19 treatment. So if patient constantly use some drugs, he has to continue these drugs even if he get COVID-19 infection. Prevention of COVID-19 infection. COVID-19 vaccination recommends for everyone who is eligible, for everyone who has no contraindication. It is strong recommendation in all countries. The risk of COVID-19 transmission can be reduced by covering coughs and sneezes and maintaining a distance of at least 6 feet from others. When consistent distancing is not possible, face covering may reduce the spread of infection droplets from individuals with SARS-CoV-2 infection to others. Frequent hand washing also effectively reduces the risk of infection. All these recommendations I hope you know very well. But rarely in practical classes, I commonly saw that students don't wear mask. When teacher is in the classes, they wear mask. When teacher go out, they take their mask away. It is not good idea, especially if you are very closely to each other. If the classroom is small and there are, for example, two groups together, or you sit very closely to each other, you have to wear mask for prevention of infection. That's all about COVID-19 for today, but not all for the lecture. We have to discuss also uh, bacterial infection and bacterial pneumonia. And also we have to discuss acute bronchitis, which may be bacterial, may be viral. Lower respiratory tract infection is an acute illness present for 21 days or less, usually with cough as the main symptom and with at least one other lower respiratory tract symptoms: fever, sputum production, breathlessness, with or chest discomfort or pain, and no alternative explanation for these symptoms, such as sinusitis or asthma. Pneumonia, acute bronchitis, and exacerbation of chronic obstructive airway disease are included in this definition. All of them are lower respiratory tract infections. Acute bronchitis, also known as chest cold, is short-term inflammation of the bronchi, large and medium-sized airways of the lungs. The most common symptom is cough. Other symptoms include coughing up mucus, wheezing, shortness of breath, fever, and chest discomfort. No, very commonly we try to differentiate acute bronchitis with pneumonia. It is, of course, difficult by clinical picture, but in general, pneumonia characterized by more severe dyspnea compared with acute bronchitis and more high temperature. And I want to pay your attention to terms. Acute bronchitis is infectious disease, but COPD is non-infectious disease. So acute bronchitis not transformed to COPD. They have different origin. Acute bronchitis may lead to exacerbation of COPD, but it not cause COPD. What is acute bronchitis? No, it is cough due to inflammation of bronchus, small and large. Inflammation may lead to narrowing of the orifice, uh, mucus hypersecretion, bronchospasm, edema of the bronchial wall, which can cause cough and dyspnea. Cough may be dry, maybe with sputum. At the beginning, it is, as a rule, dry, then transform to moist. Cough is the most common illness-related reason for ambulatory care visits. So really, before COVID-19 and now, cough is the most common reason for ambulatory care visits. Main complaint of patients who come to general practitioner. Acute bronchitis is a clinical diagnosis characterized by a cough due to acute inflammation of the trachea and light airways without evidence of pneumonia. Pneumonia should be suspected in patients with tachypnea, tachycardia, dyspnea, or lung findings suggestive of pneumonia, and radiography is warranted. The cough associated with acute bronchitis typically lasts about 2 to 3 weeks. Acute bronchitis is usually caused by viruses, and antibiotics are not indicated in patients without chronic lung disease or complication. So again, like for upper respiratory tract infection, in case of acute bronchitis, if you shouldn't use antibiotic. Only if you are sure that reason for acute bronchitis is bacteria, you may use antibiotics, but not commonly, not to each person. Clinical feature of acute bronchitis: cough with sore throat, runny nose. Accompany symptoms: fever, chest pain, fatigue, malaise. No, we have to differentiate acute bronchitis, as I told you before, mostly with pneumonia. Also with COPD, asthma, allergic reaction, common cold, congestive heart failure, even with gastroesophageal reflux disease and malignancy. No, I wanted to show you the picture with bronchitis and pneumonia. Pneumonia affect alveolus, bronchitis, bronchus, and respiratory failure, more typical for pneumonia, when like I am I'm speaking now about bacterial pneumonia, which affect some lobe or even few lobes, which decrease significantly gas exchange. Diagnosis for acute bronchitis in polyclinic in Russia rules. What is obligatory to do? To speak with patients, to make objective examination of, first of all, of respiratory system, to do thermometry, to do common blood count, and to send patient to fluorography. If fever lasts more than 3 days, instead of fluorography, better to do lung X-ray. Sputum analysis not necessary. Spirometry, C-reactive protein, and consultation by tuberculosis specialist not necessary, only if you suspect some other disease for differential diagnosis. And also you have to do, now we may add, saturation level, like obligatory diagnostic method if you suspect acute bronchitis. In X-ray examination or in fluorography, you will not see some specific change of acute bronchitis in the lung. It's not specific, but you have to do it for differential diagnosis with other disease to exclude pneumonia or malignancy. Key recommendations for acute bronchitis. Avoid prescribing antibiotics for uncomplicated acute bronchitis. Over-the-counter cough medication containing antihistamines and antitussives should not be used in children younger than 4 years because of the high potential for harm. Consider using dextromethorphan, guaifenesin, or honey to manage acute bronchitis symptoms. Avoid using beta-2 agonists for the routine treatment of acute bronchitis unless wheezing is present. Employ strategies to reduce antibiotic use, such as asking patients not hold an antibiotic prescription for a set amount of time. So don't use antibiotics. Beta-2 agonists may be used, but better not commonly. Also can be used antitussives if cough disturb patient significantly, and expectorants. Which expectorant is most common? It is guaifenesin. It has different company name, but pharmacological name is guaifenesin. Antitussive, most common in community in worldwide, is dextromethorphan. And it has also different company names. But antitussive not necessary to use, only if cough is long-lasting and disturb patient significantly. Maybe also use the same complementary and alternative medicine products for acute bronchitis like for other viral upper respiratory tract infection. Echinacea, pelargonium, dark honey in children. No different OTC medication may be used. And for outpatient treatment, it is important how long may last sick leave. It lasts up to 1 week in case of upper respiratory tract infection, usually around 1 week. And in case of bronchitis, it lasts around 2 weeks. In case of bronchiolitis, around 3 to 4 weeks, and the same length of sick leave, average length of sick leave in case of pneumonia. And now we'll try to speak about community-acquired pneumonia. When I tell pneumonia, I mean bacterial pneumonia. But I'll try to give differential diagnosis with COVID-19 lung problems. Community-acquired pneumonia, CAP, is pneumonia that is acquired outside hospital. Pneumonia that develops in a nursing home resident is included in this definition. The diagnosis is usually confirmed by chest X-ray. For bacterial pneumonia, chest X-ray is the best diagnostic method because bacterial pneumonia characterized by focal change, and CT scan is recommended very rare. Diagnostic tests which have to be done for outpatient. Physical examination have to be done, of course, and it will reveal crackles or rales, bronchial breath sound, a hypoxemia, tachypnea, cough, fever, sputum production, pleuritic chest pain. It is complaints of patient. Chest radiograph is obligatory. Observed apparent lobar or bilateral infiltrates with or without microbiological evidence. Hospitalized for suspected pneumonia but negative chest radiograph may receive empiric antibiotics with repeated chest radiograph in 1 to 2 days later. Have to be done pulse oximetry and may be done CT scan. So, chest radiograph, most typical changes in bacterial pneumonia are focal infiltrate, global infiltrate. And at the beginning, even of bacterial pneumonia, may be no specific signs in chest X-ray. In this case, if you are sure that it is bacteria, you may start antibiotic and repeat chest X-ray in 1-2 days. Now I want to show you X-ray specific for viral and bacterial pneumonia. From the left side of you with black arrows, you see viral pneumonia. You see multiple opacities in both lungs. They are spread and they are small and multiple, bilateral. For bacterial pneumonia, opacity is big, global consolidation. Red arrows show you middle lobe, left side pneumonia, bacterial pneumonia. Main reason for bacterial pneumonia in outpatient setting is pneumococcus. Now it is a question for you. Where is bacterial? Where is viral pneumonia? Of course, maybe other reasons for the same chest changes, but most typically, in one case, most common, it is bacterial pneumonia. In another case, viral. So, in the right side, when there is small patient, when there is a child, it is viral pneumonia. Multiple small opacities in both lungs. And in left side is bacterial pneumonia, focal low lobe left side pneumonia. Oh, so sorry, in previous X-ray there is bacterial pneumonia of middle lobe of right lung. I made mistake before, and here low lobe of left lung in bacterial pneumonia. What abnormalities are seen in CT scan in case of COVID-19? We already discussed it, I only remind. Bilateral peripheral ground glass opacities with the development of areas of consolidation later in the clinical course. Imaging may be normal early in infection and can be abnormal in the absence of symptoms. What is typical for COVID-19? It is ground glass opacity or subpleural consolidation. But it is not very high level of probability of COVID-19 because they are not multiple, they are single. In this situation, it is more specific, especially in picture B, because both lungs are affected. Subcortical layer is involved. So a reticular pattern present in left lower lobe and in B, right middle lobe demonstrate the crazy paving pattern from reticular pattern superimposed on ground glass opacities. Diagnostic tests in case of pneumonia when we suspect bacterial pneumonia. It's a recommendation from both countries, again from United States and from Russia. They both not recommend sputum gram stray and culture and blood cut routinely in adult with community acquired pneumonia managed in outpatient setting. Again, outpatient settings uh, may be only in patients with non-severe clinical cause of bacterial pneumonia. In this case, usually broad spectrum penicillins or cephalosporins are effective and no need to know which bacteria cause pneumonia because most common bacteria is pneumococcus and we know which groups of antibiotics are effective against this bacteria. We suggest not routinely testing urine for pneumococcal antigen in adults with community-acquired pneumonia, except in adults with severe community-acquired pneumonia. So for outpatient, no need to do. The same, no need to do urinary testing for Legionella antigen. Indications for hospitalization in patients with pneumonia. In addition to clinical judgment, we recommend that clinicians use a validated clinical prediction rule for prognosis, preferentially the Pneumonia Severity Index, PCI over the C or B 65 score to determine the need for hospitalization in adults diagnosed with community-acquired pneumonia. So C or B65 score, everybody, I hope, every doctor knows by heart. And I hope all students know this C or B65 score by heart. It is very simple, but it is less sensitive compared with PCI because it includes uh, more variants, and that's why it is more accurate. We recommend direct admission to ICU for patients with hypertension requiring vasopressors or respiratory failure requiring mechanical ventilation. For patients not requiring vasopressor or mechanical ventilation support, we suggest using IDCA ATS 2007 minus severity criteria together with clinical judgment to guide the need for higher levels of treatment intensity. So we use C or B and PCI score to know to hospitalize patient or not. Or if more simple, we hospitalize moderate and severe clinical cases with pneumonia, severe in intensive care unit. But I want to remind you C or B 65 score. C means confusion. U, raised blood urea nitrogen, and score will be positive if blood urine nitrogen is over 7 millimole per liter. Raised respiratory rate, more than 30 breathing per minute, and low blood pressure, not high, low, diastolic less than 60 and systolic less than 90 millimeter mercury. And 65 means age. If total score is 0 or 1, patient may be treated at home. Consider hospital-based care for patients with CRB 65 score of 2 or more. Consider intensive care assessment for patients with CRB 65 score of 3 or more. And it is very simple score and is good because it is simple, but more sensitive is pneumonia severity index algorithm. But it is very difficult to remember by heart. I only want to demonstrate all items of PCI score. There are some clinical pictures. You see many clinical pictures, some anamnestic data, some demographic, comorbidity, physical exam finding, lab and radiographic finding. And each of them will give some bulk. And then we have to make sum of all these bulk. And if sum is less than 70, risk class 2. 71, 90, risk class 4. More than 90 up to 130, risk class 4, and more than 130, risk class 5. Risk class 1 or 2 pneumonia patient can be sent home on oral antibiotic. Risk class 3 patient may be sent home with oral antibiotic or may be hospitalized. Risk class 4-5 patients have to be hospitalized. Community-acquired pneumonia treatment in outpatient setting. We are speaking about bacterial pneumonia. For healthy outpatient adult without comorbidities, we recommend one of antibiotics, amoxicillin, doxycycline, or macrolide. So penicillin, tetracycline, or macrolide. It is United States recommendation. In Russian recommendation, we avoid tetracycline because in our community is higher level of resistance to tetracycline antibiotics. So we prefer amoxicillin, or if not effective, or patient has allergic reaction, for example, to amoxicillin, we can use macrolide, azithromycin, or clarithromycin. In patient with non-severe clinical course of pneumonia, but with comorbidities such as chronic heart, lung, liver, or renal disease, diabetes mellitus, alcoholism, malignancy, or asplenia, we recommend combination therapy, amoxicillin plus clavulanic acid. So clavulanic acid is inhibitor of penicillinase. So it's increase spectrum of amoxicillin and increase effectiveness of this treatment. Also may be used cephalosporin antibiotics, mostly third generation cephalosporin, no, very commonly ceftriaxone, cefuroxime, and other third generation cephalosporin. May be used azithromycin, clarithromycin, or doxycycline. Also can be used respiratory fluoroquinolone. We suggest that anti-influenza treatment be prescribed for adults with community-acquired pneumonia who test positive for influenza in the outpatient setting, independent of duration of illness before diagnosis. We recommend the standard antibacterial treatment be initially prescribed for adults with clinical and radiographic evidence of community-acquired pneumonia who test positive for influenza in the inpatient and outpatient settings. It is old recommendation before COVID-19 pandemic. And that's why doctors so commonly try to use antibiotics in viral pneumonia because it was recommended in patients with severe influenza. But COVID-19 is more dangerous, more widespread infection, and it's impossible to use antibiotics for prophylaxis. We may use it only for treatment when we are sure that present not only viral but bacterial infection. So these recommendations are old recommendations and now not shouldn't be used. Treatment duration and follow-up in bacterial pneumonia. We recommend that the duration of antibiotic therapy should be guided by a validated measure of clinical stability, resolution of vital sign abnormalities, heart rate, respiratory rate, blood pressure, oxygen saturation, and temperature, ability to eat, and normal mentation. And antibiotic therapy should be continued until the patient achieve stability and for no less than a total of 5 days. In an adult with CAP whose symptoms have resolved within 5 to 7 days, we suggest not routinely obtaining follow-up chest imaging. So, usually antibiotics in non-severe clinical cause of pneumonia last around 5-10 days, not less than 5 days. And we may stop antibiotic treatment when patient improve his symptoms and when patient temperature is normal around 2 days. After it, you may stop antibiotic treatment, but other symptoms can be present. In 1 week, fever should be resolved in case of community-acquired pneumonia. In 4 weeks, chest pain and sputum production should have substantially reduced. So, 1 week, fever resolved and antibiotic you will stop. But chest pain and cough with sputum may be present. You have to ensure patient that it is not dangerous too much, that no need to continue antibiotics. 6 weeks may last cough and breathlessness. In 3 months, most symptoms should have resolved, but fatigue may still be present. And only in half of a year, most people will feel back to normal. And prevention. Vaccination against streptococcus pneumonia and influenza virus. Vaccination status should be assessed at the time of admission. Vaccination should be performed either at discharge or during outpatient follow-up if needed. And also risk factor modification. Smoking and alcohol abuse cessation. And I want to tell, before I tell you goodbye, I want to tell you very small. Vaccination against Streptococcus pneumonia should be given in all patients with comorbidity like asthma, COPD, in patients with high risk of infection, who has contact with patients, for doctors, for nurse, who has contacts with patients with pneumonia. So I strongly recommend you to, if you will work in future with patients with infectious disease, to underwent vaccination against Streptococcus pneumonia and influenza virus for prophylaxis of these severe diseases in yourself. And of course, smoking and alcohol abuse is recommended for everyone, for patients and for doctors. So be healthy and wealthy, and I wish you the best. Thank you for your attention and goodbye.
У нас все по.
Вы что-то мне сказали?
Я стараюсь просто сказать.
Я слышу, Татьяна Александровна, знаете, не слышу.
Я сказала, остальное не
А,
важно.
вы тоже такой?
Да, да.
А я еще на второй, так сказать, написала. До свидания. А вы русских читаете, Татьяна Александровна? Тоже обратите внимание, нет?